Assalamu alaikum ji. Bismillahir Rahmanir Rahim. We've been talking about left main stem, ISR, retrograde PCI. All of these angioplasties are done in a rather planned manner. And I'll be talking about a few cases of primary PCI where most of the cases are done at odd times and they do not let you plan beforehand what you have to do. So, primary, can I have the first slide, please? Yes. Next slide. यार ये किस तरह Okay. So primary PCI is an established treatment of acute myocardial infarction. It has proven to be better than thrombolysis. Generally, primary PCI cases, we know that these infarctions happen in non-critical lesions and they present early. We have done within first 12 hours. Thrombus generally soft. They are not generally very challenging. However, one can face unusual situations or complications which may require technical skills, expertise, and instant decision making. A few cases are presented. Now, my first case is a case of hypertension, 3 hours chest pain, ECG revealed acute anterior myocardial infarction, and there was no contraindication to primary PCI. So we take him to the cath lab, and here we see, you can see there is a tight distal left main stem stenosis. We stopped there. We offered primary PCI, but the patient, of course, declined. And we also note that the surgeons hardly take over these kind of patients. So we now look at this again. This is left main to LAD disease. We can circumflex is non-dominant. The osteoma of the circumflex is not significant disease. So this is a simple bifurcation. So we made a crossover strategy, and we were able to balloon and then stand, and that was the pot, and then that's the final result. Okay. So the crossover standing from left main to left anti-descending is technically easy. The decision of crossover is easy when the circumflex is non-dominant, small size with a healthy looking ostium. And it provides a quick fix in unstable situation where cabbages decline. So that's the next case. The 39-year-old male presented with chest pain for 7 hours, and we had an acute inferior MI on ECG. And here you can see there is a lot of ectasia on the left system. And then we took a picture of the right, and you can see there is not only is ectatic, it is full of thrombus. Once we wired the RT, we could see that there is an early bifurcation. So we put in another wire, and we decided to do thrombus aspiration of the lesion. So after many runs of thrombus aspiration, we still had a lot of thrombus activity. We started the tyrofluban infusion, and we decided to postpone or defer the stenting. The patient was kept on a dual antiplatelet and apixaban 5 mg twice a day. Angiogram was done 5 weeks later, a few days later, but still there was thrombus, and then again repeat after 5 weeks. Here you can see the thrombus has largely resolved, and there is good flow. So stenting of an ectatic vessel in a primary situation can be deferred after thromboaspiration. Thromboaspiration is, although not indicated these days, but still can be of use in lesions with very heavy clot burden. So next case is a history of, he already had history of PCI to the LAD, and he presented with acute stent thrombosis, very late stent thrombosis. And we started the angioplasty. You can see that the guide cath has moved forward. There's an inadvertent movement of the guide cath, which led to an ostial dissection of the LAD. So these, one has to be very careful in handling the guide cath, XP3 guides, because we cannot make a selection before the procedure. We normally, for the left-sided lesions, primary PCI we take a XP3 guider. So one has to have a careful handling, and one need to have change the strategy. We have to cover the dissection also. So again, fairly good result. So change of standing strategy can be there, and meticulous handling with the guide cath is essential. Next case is a patient again of ECG present with posterior MI. There was a simple lesion in the circumflex. We started the angioplasty, we ballooned it, put a stent, and see what happens. Now here was the inexperienced operator. He, after the stenting, pulled the balloon in haste, and the guide cath got pulled in, and there was a dissection of the circumflex ostium. Now the patient had chest pain and had a cardiac arrest kind of thing. Then CPR, he was able to revive, and we had to stent from left main into the circumflex. Then we had to open the stent starch into the left main, post-dilated the circumflex stent, finished off with kissing, and we were able to have done a port, and then finally we were able to have a good result. So it is critical to avoid forward movement of the guide cath while removing balloon or stent delivery balloon. Totally deflated balloon, when pulled back, is less likely to cause forward movement of the guide cath. Haste makes waste. So next case is a patient who presented with history of chest pain. He had a borderline blood pressure 90-60, even after giving him some intravenous fluids. He had a tachycardia, and ECG revealed an ST elevation in greater than lead 2 than in lead 3, along with the ST elevation in lateral leads. So we took it looked like a circumflex occlusion. We took took him to the cath lab and did this angioplasty. And you can also see that the left the right cornea also is cross-filling, and left is also occluded. So this is after every injection, the patient's blood pressure would come down to about 70. So this was a cardiogenic shock situation. In this patient, only the target vessel should be attempted. So we did a primary PCI to the circumflex, and we got a good result. And we had RCA total occlusion. So limit yourself in a cardiogenic situation to only culprit lesions. Later on, he was referred to the surgeon. Now, ECG generally tells the truth, if not the whole truth always. It's recommended to avoid multi-vessel PCI in cardiogenic shock settings. Now, next patient is a case with the inferior MI, which had some reciprocal changes in the lateral leads. And here you can see there is a critical disease in the mid LAD as well as the diagonal. But as the ECG showed inferior MI, we went on to took a picture of the right, and there was occlusion of the right. We did PCI of the right, but the patient continued to have chest pain. And he had such a persistent ongoing chest pain that I decided to do another ECG right on the table, and here it was. Then he firstly had changes in the inferior lead. Now he has severe S segment depressions in the anterior leads. So we went back and fixed the LAD also, LAD and the diagonal also. So at times you have to do multi-vessel PCI in a primary setting, not as a choice but as a compulsion. So after this procedure on the left side, we had a fairly normalized ECG. Now take one point is that primary PCI settings, multi-vessel PCI as opposed to culprit only, can be done during index procedure if the patient has persistent symptom and is not having cardiogenic shock. Now next case is a patient, he came with chest pain for 6 hours duration, had anterior MI, and then angiogram showed a densely calcific tortuous LAD and a focal lesion in the mid LAD, and it looked like a simple primary PCI, except that there was a bit of tortuosity and calcification. So we can, once we started, we couldn't cross a balloon, and we did ballooning, and that led to no reflow, and there was a dissection. I'm just quickly running through because short of time. So we gave a lot of adenosine for the no reflow. We would balloon. We couldn't take the stent into the LAD. We decided to take guide sport catheter, and then we changed the wire also, Grand Slam wire, and then we had a dissection of the left main stem. So in a complex situation, in a calcific lesion, subtotal occlusion, these things can happen. So we are now faced with a situation where not only we have an LAD occluded, but the dissection in the left main also. So we thought we should save the left main stem first. We stented the left main stem, and we were able to achieve recanalization of left main stem, but we decided to leave the culprit lesion alone. Patient made an uneventful recovery and remained stable, and later on he was kept on medical treatment. Dealing with tortuous calcific vessels is always challenging, and one must accept failure when success is not achieved. Now the next case is a patient is diabetic, hypertensive, and had bypass, and here you can see the left system, and we have then right system also gone. And here you can see the graft to the diagonal is occluded, lima is patent. Now PCI of vein grafts is generally not very successful, but in case of primary PCI settings we should attempt these, and here we see we were able to get a very good result in a vein graft. So vein graft in acute situations where no other choice available should be attempted, and we can get a very good result. So next, now last case, of course, he's moving, So if there's ST elevation lead 3, this is RC occlusion. If there's ST elevation in lead 2, this is generally circumflex occlusion. And if there's a failure of axis segment to go down in the V1, or there's elevation V1, V2, there is an RV infarction and generally a proximal RC occlusion. And if there is a lot of ST elevation and there is V5, V6 are also gone, showing elevation is probably an extensive or a dominant circumflex artery disease. Here I show the last case. This is a patient who presented with the ECG of pattern of the circumflex occlusion. He had also he had also a heart valve. We had to put in a pacemaker, and we did this. Let it run. So we can see there is a occlusion of circumflex in the proximal course, and we were able to treat this. And then I left and asked my colleague to take a picture of the right, and we could go on. Then we can see here the right is also occluded. So this is a little unusual. We can have acute coronary syndrome where the two arteries can be occluded. So we had to fix the RC also. So that was the final result. So take home message here is the ECG of great help, but accept the unexpected in PCI. One has to learn to handle the equipment meticulously. Do not let the guide cath move inadvertently. Multiple PCI sometimes is not a choice but is essential. In a stemic setting patients in post-cabbage patients, do whatever you can do. Always expect and always have an expert available to you if you are not well experienced. Thank you very much.